Welcome to the Alabama Newborn Screening Program. I'm Sarisha Johnson, Nurse Educator with the Newborn Screening Program. This video is designed to provide you with a comprehensive overview of the Newborn Screening Program in Alabama. We will discuss the disorders that are currently included on the primary panel of disorders, describe appropriate hearing screen methods, and identify the 7 critical congenital heart defects that can be detected through pulse oximetry screening. Newborn screening began in the 1960s when Dr. Robert Guthrie developed a test that could detect phenylketonuria, also known as PKU, from a single dried blood spot. In 1964, Alabama began screening for PKU using the Guthrie screening method. Since then, Alabama has added a total of 31 primary disorders to the newborn screening panel, which is currently mandated by law. Today, newborn screening is the description given to 3 simple procedures that can help identify infants with certain serious genetic and inborn conditions even before they show signs and symptoms. These are usually completed at the hospital of birth by 2 days of age. Newborn screening includes a newborn blood spot screen, a newborn hearing screen, and a pulse oximetry screen. The initial blood spot screen should be collected on all infants by 48 hours of age. This helps to ensure timely screening for critical conditions that can cause symptoms as early as the first week of life. This test requires 5 large drops of blood, approximately 1/10 of cc each, to be applied to the filter paper portion of a specially manufactured collection form which is provided by the Alabama Bureau of Clinical Laboratories. The newborn hearing screen should be done at least 12 hours after birth and can be completed by one of 2 methods: the otoacoustic emissions or OAE screen or the automated auditory brainstem response or AABR screen. The pulse oximetry screen should be completed at 24 to 48 hours of age to detect the possible presence of a critical congenital heart defect or CCHD. Currently, Alabama screens for 29 primary conditions from the newborn blood spot screen. For this reason, it is no longer accurate to refer to the blood spot screen as the PKU. It should now be called the newborn screen or newborn blood spot screen instead. This screen is used to detect the possible presence of sickle cell disease and related hemoglobinopathies. However, this is only routinely completed on the initial screen, which is usually collected on the A form. Newborn screening also tests for cystic fibrosis, the endocrine disorders congenital hypothyroidism and congenital adrenal hyperplasia, Biotinidase deficiency, Galactosemia, severe combined immunodeficiency disease, and a panel of metabolic disorders. Sickle cell disease is among the more prevalent conditions that are identified through newborn screening. This autosomal recessive condition occurs when a child inherits an abnormal hemoglobin gene from each parent. When both parents are carriers, meaning they have one abnormal gene but no disease, each of their children has a 25% chance of inheriting no gene mutations, a 50% chance of also being carriers, and a 25% chance of having the disease, as illustrated in this slide. Sickle cell disease is characterized by the shortage of healthy red blood cells, which are necessary to transport oxygen throughout the body. This shortage results from abnormal, misshapen sickle cells, which are less efficient at transporting oxygen, as well as from the shorter cell life of these abnormal cells. While a normal red blood cell lives approximately 120 days, or 4 months, a sickle cell only has a lifespan of 10 to 20 days, or less than 3 weeks. This significantly reduces the volume of circulating mature red blood cells. There are 3 hemoglobinopathies that newborn screening is intended to identify. Sickle cell anemia is the most severe form and is what many people think of when they hear sickle cell disease. Sickle cell anemia occurs when a child inherits the sickle cell gene or S gene from each parent. Sickle hemoglobin C disease is another form in which the child inherits the S gene from one parent and the C gene, another abnormal type of hemoglobin, from the other parent. While not as severe, Individuals with sickle hemoglobin C disease can still have serious health problems from the condition. Hemoglobin S beta thalassemia is another abnormal hemoglobin condition in which a child inherits the S gene from one parent and an abnormal hemoglobin gene for beta thalassemia from the other. While less severe, it is important that infants with any of these conditions receive a referral to a pediatric hematologist for diagnostic testing to include a hemoglobin electrophoresis. In addition, the family should be educated on the importance of regular medical care and follow-up, especially during times of illness. The varying signs and symptoms that accompany these abnormal hemoglobin conditions can include anemia, which is caused by the decreased number of red blood cells. In turn, the subsequent decrease in oxygen to the body can cause chronic fatigue. The abnormal sickle cells, because of their rigidity and sickle shape, do not flow as freely through the blood vessels. This can lead to the clumping of cells in various vessels of the body, causing painful episodes or pain crises, as well as painful swelling in the extremities. The vaso-occlusion can also cause damage to multiple body systems. Damage to the spleen can lead to poor immune response and increased infections. The occlusion of the small blood vessels that supply the eye can lead to retinopathy and other vision problems. Occlusion of the blood vessels to the brain can lead to stroke. Because of the multi-system effect of sickle cell disease, these children also experience delayed growth and are usually smaller than their peers, experiencing puberty at a later age. In addition to sickle cell disease, newborn screening also identifies sickle cell trait and C trait, as well as some less common abnormal hemoglobin results. Cystic fibrosis is another autosomal recessive condition that can be caused by a combination of more than 1,500 genetic mutations. However, the majority of cases seen in Alabama are caused by only a small percentage of known mutations. In Alabama, screening for cystic fibrosis is completed using a two-tier approach. Primarily, the immunoreactive trypsinogen, or IRT, is measured. After that has been completed, the Bureau of Clinical Laboratories Newborn Screening Lab determines which specimens fall within the top 4% of IRT levels for the day. Those specimens are further tested to identify the presence of the most common CF mutations. Any IRT result above 170 or any identified mutations are reported as abnormal and follow-up is initiated. Because cystic fibrosis carriers can also have elevated IRT levels, they are sometimes identified through newborn screening. However, this is not the intent of the newborn screening program. Cystic fibrosis is laboratory confirmed by sweat test, which detects abnormally high levels of sweat chloride. Genetic testing may also be used to help confirm a diagnosis. It is recommended by the Cystic Fibrosis Foundation that any infant requiring a sweat test be referred to their nearest accredited cystic fibrosis care center. Currently, the only one in Alabama that specializes in pediatric care is located at Children's of Alabama in Birmingham. Cystic fibrosis occurs because of mutations in the gene which makes a protein called cystic fibrosis transmembrane regulator, or CFTR. A person with cystic fibrosis produces abnormal CFTR protein or no CFTR protein at all, which causes the body to make thick, sticky mucus instead of the thin, watery kind that is normally present in the body. As a result, individuals with cystic fibrosis can develop severe respiratory and digestive symptoms such as persistent cough with thick, hard-to-clear mucus, frequent lung infections, poor weight gain and growth, and in infancy, a condition called meconium ileus, in which abnormally thick meconium causes an infant's bowel to be blocked at birth. In addition, cystic fibrosis can cause nasal polyps and other sinus problems, abnormal pancreatic function and diabetes, gallstones, liver disease, and enlargement of the heart. In order to reduce the effects of cystic fibrosis, there are a number of treatments that may be required. Antibiotics are used to treat frequent infections, while bronchodilators, oxygen therapy, anti-inflammatories, and mucus-thinning medications help to open up the airway and make breathing easier. Oral pancreatic enzymes aid in the digestion of food, and vitamin supplements replace the nutrients that are not readily absorbed. More invasive procedures may be needed to remove blockages such as nasal polyps or bowel obstructions. In severe situations, lung transplantation may be required. There are two endocrine disorders that newborn screening also helps to identify. Congenital hypothyroidism is a condition caused by inadequate thyroid hormone. While it can be inherited, over 80% of cases occur spontaneously as a result of a poorly formed or absent thyroid gland. Congenital adrenal hyperplasia describes a group of autosomal recessive inherited conditions that affect the adrenal gland. The thyroid gland is a butterfly-shaped gland that is located in the neck. When functioning properly, it produces hormones that regulate metabolism, heart, and digestive function, muscle control, brain development, and bone maintenance. Its function is dependent upon receiving sufficient iodine from the diet. When congenital hypothyroidism occurs, infants usually appear normal at birth, but soon begin to show signs and symptoms such as decreased activity, poor feeding and weight gain, jaundice, decreased stools or constipation, poor muscle tone, and hoarse cry. This may be accompanied by coarse facial features, large fontanelles, umbilical hernia, mottled cool-dry skin, pallor, and goiter, and will lead to developmental delay without prompt diagnosis and treatment. Because of the thyroid's importance in brain development, it is critical that congenital hypothyroidism be identified and treated within the first weeks of life. The Bureau of Clinical Laboratories screens for the thyroid-stimulating hormone, or TSH, and thyroxine, or T4 levels. If the TSH is elevated following age-dependent cutoffs, the result is immediately reported to the infant's medical home and serum labs are requested. In addition, consultation with a pediatric endocrinologist is recommended to determine appropriate treatment and follow-up care. The overreaching goal is to normalize thyroid hormone blood levels and eliminate all signs and symptoms of hypothyroidism in order to prevent permanent developmental and intellectual disabilities. This is best achieved by initiating treatment with levothyroxine as soon as possible and ideally before 2 weeks of age. The adrenal glands are small triangular-shaped glands located above the kidneys. They produce hormones that regulate metabolism, immune system, blood pressure, response to stress, and other essential functions. In a person with congenital adrenal hyperplasia, or CAH, the adrenal glands are very large and unable to produce certain chemicals, including cortisol, a chemical that helps protect the body during stress or illness and helps regulate the amount of sugar in the blood. Left untreated, the adrenal glands also produce too many androgens, the hormones responsible for male sex traits. There are three main types of CAH: salt wasting, simple virilizing, and non-classic. Each is classified by the amount of hormones produced and the subsequent symptoms they cause. The primary hormones involved are cortisol, the hormone that responds to stress, aldosterone, the salt-regulating hormone, and androgens, which produce male sex traits. Salt-wasting classic CAH is the most severe form and makes up 75% of classic CAH cases. Symptoms usually begin in the first few weeks of life and may include poor feeding, prolonged or more frequent periods of sleep, vomiting, diarrhea, weight loss, irritability, rapid heart rate, male-like genitalia in females, and the early onset of puberty. Additionally, the adrenal glands do not produce adequate aldosterone, making the body unable to retain enough sodium, leading to dehydration and electrolyte imbalance. Salt-wasting CAH can become life-threatening, leading to coma and death if left untreated. Simple virilizing classic CAH accounts for 25% of classic cases. This form is less severe than salt wasting but more severe than non-classic. Symptoms begin before birth and typically are only initially evident in females. They often have an enlarged clitoris which may resemble a small penis, and the labia may be fused together to resemble a scrotum. Early onset of puberty can occur in both males and females. With this type of CAH, the adrenal glands produce enough aldosterone, therefore this does not produce the life-threatening, salt-wasting effects seen in the more severe form. Non-classic or late-onset CAH usually causes milder effects than classic CAH. However, symptoms can be quite variable from person to person. Many people with non-classic CAH start showing signs during childhood, adolescence, or early adulthood. Others never develop symptoms. Newborn screening can detect some, though not all, babies with non-classic CAH. Not all CAH is treated the same. Classification and clinical presentation must be taken into account. Treatment may include salt replacement and/or hormone replacement with hydrocortisone to replace cortisol and fludrocortisones to replace aldosterone. The doctor may also prescribe medications such as human growth hormone supplements to help regulate growth, since children with CAH can experience delayed or rapid growth. Surgery to correct ambiguous genitalia may be necessary for some females. This is a very complex decision that should be considered on an individual basis. Some families may proceed with corrective surgery during infancy, whereas others may elect to wait until the child is older and can be involved in the decision. Biotinidase deficiency, also an autosomal recessive condition, occurs when the body has decreased or non-functioning biotinidase, an enzyme which is necessary to reuse and recycle the vitamin biotin. The vitamin biotin is needed to break down fats, proteins, and carbohydrates. There are two types of biotinidase deficiency which differ in severity and treatment. These are profound biotinidase deficiency, which is considered severe, and partial biotinidase deficiency, which is milder. The early signs and symptoms of profound biotinidase deficiency may include seizures, weak muscle tone, difficulty breathing, hearing and vision problems, issues with movement and balance, skin rashes, hair loss, candidiasis fungal infections, and developmental delay. Many of these can be triggered by illnesses or infection. Partial biotinidase deficiency has some of the same symptoms, such as hypotonia, skin rashes, and alopecia, although these may only occur during illness or times of stress. Treatment for both types often requires lifelong biotin supplements, since affected individuals usually do not have enough of it in their body. This natural vitamin helps affected individuals to break down the nutrients found in foods so that fats, proteins, and carbohydrates do not accumulate in the blood, causing harmful effects. With prompt identification and treatment, healthy growth and development is likely, as it will prevent irreversible complications such as developmental delay, eye abnormalities, and hearing loss. Galactosemia is an autosomal recessive metabolic condition in which the body is unable to metabolize galactose, a sugar found in all foods that contain milk. In an affected individual, these undigested sugars build up and become toxic in the blood rather than being used for energy. While there are several types of galactosemia, this presentation will focus on what is known as classic galactosemia. Signs and symptoms of galactosemia can occur within a few days of birth and may include poor weight gain and growth, poor feeding, vomiting, diarrhea, excessive sleeping, lethargy, irritability, and low blood sugar. Treatment involves the avoidance of foods containing galactose or milk sugar to prevent toxic buildup of undigested sugars in the blood. Because many affected individuals must avoid all milk products, they may also require calcium supplements. In addition, vitamin C or vitamin K may be prescribed. Even with strict diet adherence, a small amount of undigested sugars made by the body may still build up, causing some affected children to have delays in learning, development, speech and language, and motor skills. However, without treatment, they will develop vision problems, liver damage, hypoglycemia, blood infections, developmental delays, and intellectual disabilities. Babies who do not receive treatment can die within their first weeks or months of life. Severe combined immunodeficiency, also known as SCID or bubble boy disease, is the newest disorder to the Alabama Newborn Screening Panel. This inherited condition occurs when parts of the immune system do not function properly, leaving an infant susceptible to serious and life-threatening infections. Specifically, T cells and B cells, which are types of white blood cells that are important to our immune system, are not produced in sufficient quantity or do not function properly. Shown here is David Vetter, a child with SCID who was placed in a bubble environment specifically constructed to try to protect him from infections. He eventually died from a viral infection contracted during bone marrow transplant. Early signs of SCID include frequent infections, infections that do not improve with treatment, diarrhea, failure to thrive, and thrush that does not resolve. Those classified as amino acid disorders are arginosuccinic aciduria, citrullinemia, type 1, maple syrup urine disease, homocystinuria, phenylketonuria or PKU, and tyrosinemia type 1. Amino acids are the building blocks of proteins and serve many functions in the body. Hereditary disorders of amino acids can result from defects either in the breakdown of amino acids or in the body's ability to get amino acids into the cells. Although rare, PKU is the most commonly diagnosed amino acid disorder. While symptoms vary between the amino acid disorders, they may include irritability, poor appetite, vomiting, increased sleeping, lethargy, seizures, and developmental delays. If left untreated, an amino acid disorder can lead to brain damage, coma, or even death. Just like the symptoms, treatment varies among the amino acid disorders. Typically, these disorders are managed with dietary restrictions, which may include special formula and foods. In addition, specific medications or supplements may be required to better manage certain conditions. Even with treatment, some disorders can still cause symptoms that require additional medical care. Alabama currently screens for the following fatty acid disorders: carnitine uptake and carnitine transport defect, medium chain acyl coenzyme A dehydrogenase deficiency or MCAD, very long chain acyl coenzyme A dehydrogenase deficiency or VALCAD, long chain L3 hydroxyacyl coenzyme dehydrogenase deficiency or LCHAD, and trifunctional protein deficiency. Although rare, MCAD and VALCAD are the most commonly diagnosed fatty acid disorders. The fatty acid disorders are classified by the inability to convert some fats into the energy needed for the body to function. Instead, too many unused fatty acids build up in the body. Signs and symptoms include tiredness and increased time sleeping, irritability and behavioral changes, poor appetite, fever, vomiting, diarrhea, and low blood sugar. When left untreated, these disorders can lead to brain damage and death. Treatment usually includes a high carbohydrate, low fat diet in order to avoid the specific types of fat that the body cannot break down. However, carnitine deficiency is a disorder that is managed with carnitine supplementation alone. The physician or specialist may also prescribe supplements or medication to aid in the breakdown of fats and help provide needed nutrition. In addition, frequent meals help to maintain blood sugar. This is particularly important in times of illness. The organic acid disorders include propionic acidemia, methylmalonic acidemia, both methylmalonyl coenzyme A mutase and cobalamin disorders, isovaleric acidemia, 3-methylcrotonil coenzyme A carboxylase deficiency, 3-hydroxy-3-methylglutaric aciduria, holocarboxylase synthetase deficiency, beta-ketothiolase deficiency, and glutaric acidemia type 1. Newborn screening includes a newborn hearing screen, which should be completed prior to hospital discharge. An additional hearing screen of both ears, when necessary, should be completed prior to 1 month of age. This screen helps to identify infants with a potential hearing loss before developmental delays become evident. A non-pass or refer result does not necessarily mean that an infant has a hearing loss. However, it is important not to minimize the importance of follow-up testing. In addition, parents should be educated regarding the impact that even slight hearing loss can have on speech and language development, because every parent should be given the opportunity to be an effective advocate for their child. As previously mentioned, there are two available screening methods that can be used. Both are painless, non-invasive procedures that usually only take a few minutes to complete. The otoacoustic emission screen, or OAE, determines inner ear function by measuring the sound produced by the vibration of the hair cells when stimulated by sound. This is completed by placing a small probe into the ear canal. Because OAE screening cannot accurately screen for certain types of hearing loss, it is important that any infant in NICU or with known risk factors be screened using the AABR method. The Automated Auditory Brainstem Response, or AABR, is the more comprehensive hearing screen method. By placing electrodes on the head and neck while soft sounds are heard through a small probe or earmuffs, brain wave response can be measured. This is currently the only newborn hearing screen method that can detect auditory neuropathy spectrum disorder, also known as auditory dyssynchrony. Therefore, this is the screening method needed for infants in NICU or with other known risk factors for hearing loss. In addition, an AABR should be completed as the follow-up screen for any infant that initially did not pass an AABR. This illustration indicates the screening capability that AABR provides compared to OAE. As you can see, OAE screening stops at the inner ear, whereas AABR can also indicate when the cochlea or hearing nerve are not processing sounds normally. The Joint Committee on Infant Hearing created guidelines for universal newborn hearing screening, which included the implementation of the Early Hearing Detection and Intervention, or EHDI program. Specifically, the 2007 position statement states, to maximize the outcome for infants who are deaf or hard of hearing, the hearing of all infants should be screened at no later than 1 month of age. Those who do not pass screening should have a comprehensive audiological evaluation at no later than 3 months of age. Infants with confirmed hearing loss should receive appropriate intervention at no later than 6 months of age from healthcare and education professionals with expertise in hearing loss and deafness in infants and young children. Although initial hospital hearing results are received by the Alabama Newborn Screening EHDI program electronically, it is important that all outpatient hearing screens and diagnostic evaluations be reported using the form shown. Pulse oximetry screening was implemented in Alabama in 2013. This painless, non-invasive procedure should be completed on all well infants between 24 and 48 hours of age. By estimating blood oxygen saturation in the right hand and either foot, low saturations or discrepancies in results can help identify critical congenital heart defects. This screening can be completed simultaneously or in sequence according to the standardized algorithm. Following this algorithm, appropriate follow-up can be initiated in a timely manner, often before the presentation of other signs and symptoms. For accurate screening, it is important that an infant is warm and quiet on room air and that both pulse oximetry sites are clean and dry. As shown here, a result of 95% or higher in the right hand and foot with a 3% or less difference is a passing result. But any saturation less than 90% is an immediate fail. Any infant who fails the screen should have an evaluation for causes of hypoxemia, which often includes an echocardiogram and consultation with a pediatric cardiologist. In addition, any infant who fails the pulse oximetry screen should be reported to the Alabama Newborn Screening Program using the CCHD reporting form shown here. You can obtain a copy of this form at the link shown. Before we discuss the 7 critical congenital heart defects, let's review circulation through a normally developed heart. You can follow along in the illustration. Oxygen-poor blood returns from the body via the superior vena cava and the inferior vena cava and enters the right atrium. It then flows through the tricuspid valve into the right ventricle, where it is pumped through the pulmonary valve into the main pulmonary artery, which travels to the lungs to be oxygenated. Oxygen-rich blood returns to the heart via the pulmonary veins and enters the left atrium. It flows through the mitral valve, into the left ventricle, then through the aortic valve and out the aorta to the body. Although pulse oximetry screening may not detect every congenital heart defect, newborn screening is intended to detect these 7 critical congenital heart defects, or CCHDs. By doing so, surgical intervention can often be initiated before serious signs and symptoms occur. Hypoplastic left heart syndrome occurs when the left side of the heart does not properly develop. This affects the mitral and aortic valves, the left ventricle, and the aorta. Because the left side of the heart cannot pump sufficient blood out to the body, the ductus arteriosus must remain open to allow the right ventricle to support circulation to the lungs and body. Pulmonary atresia with intact septum occurs when the pulmonary valve does not form correctly, which obstructs blood flow from the right ventricle to the lungs. In order for blood to reach the lungs for oxygenation, it must flow through a patent foramen ovale, then backwards from the aorta through a patent ductus arteriosus. Tetralogy of Fallot is a combination of 4 heart defects: a ventricular septal defect, pulmonary stenosis, aortic valve enlargement, and displacement and thickening of the right ventricle wall. This causes a reduction in blood oxygen saturation to the body due to the decreased oxygen flow to the lungs and the mixing of blood in the heart. Total anomalous pulmonary venous return, or TAPVR, occurs when none of the main pulmonary veins is attached to the left atrium. It is more severe if there is a blockage in the pulmonary veins. This cardiac defect is immediately fatal if blood cannot return to the right atrium and flow into the left. This is made possible by a large atrial septal defect or a patent foramen ovale. Transposition of the great arteries occurs when the pulmonary artery and aorta are swapped or transposed so that the aorta is attached to the right ventricle and the pulmonary artery is attached to the left. This condition is immediately fatal if a ventricular septal defect is not present, since oxygenated blood has no other way to flow out into the body. This cardiac defect causes oxygen-poor blood from the body to be recirculated to the body while oxygen-rich blood continues to circulate between the heart and lungs. However, with the presence of a ventricular septal defect, blood can mix in the heart, supplying oxygen-rich blood to the body. Tricuspid atresia, as the name implies, affects the tricuspid valve between the right atrium and ventricle. This blocks blood flow between these heart chambers so that blood cannot enter the pulmonary artery to receive oxygenation in the lungs. Since blood is unable to flow correctly, infants with this defect often also have an atrial septal defect or a ventricular septal defect, which allows blood to mix so that oxygen-rich blood has a way to be pumped to the body. Truncus arteriosus is a heart defect that occurs when one large vessel, the truncus arteriosus, comes out of the right and left ventricles instead of the two normal vessels, the pulmonary artery and the aorta. This is usually accompanied by a ventricular septal defect. As a result, blood mixes and too much blood flows to the lungs. This causes breathing difficulty and damages the pulmonary vessels. If not corrected, it leads to pulmonary hypertension, which is life-threatening. Newborn screening began as a way to identify PKU before symptoms could negatively impact an infant. Once just a single test, it has evolved so that we now screen for over 50 primary and secondary conditions from 5 drops of blood. Every year, around 12,000 affected infants are identified through newborn screening, allowing them to receive treatment and specialized care before signs and symptoms have a permanent impact on their health. This is why the Centers for Disease Control and Prevention has called newborn screening one of the greatest public health achievements of the 20th century. This video was designed to provide an overview of newborn screening in Alabama. Please visit our website for additional information and resources. You may also contact us by phone or email if you have any questions or concerns. Thank you for taking the time to learn more about newborn screening.